I want to start with something that I think about more than most people would expect a doctor to think about. I think about the patients I have lost who felt fine, not patients who ignored symptoms, not patients who refused care or missed appointments, patients who genuinely felt well, who walked their dogs and cooked dinner and laughed with the people they loved in the days and weeks before their stroke, who came in for a routine check, got a normal blood pressure reading, and left feeling reassured. And then something happened, without warning, without the dramatic buildup that most people imagine must precede a cardiac event. Simply, the accumulated pressure of years of undetected nighttime hypertension, silently damaging arterial walls and kidney tissue and the tiny vessels behind the eyes, until the margin of compensation ran out. This is not a rare story. It is far more common than most people realize. And the reason it keeps happening, the reason this gap between feeling fine and not being fine persists, is something I want to spend the next 20 minutes explaining to you as clearly as I can. Because there is a diagnostic blind spot in how blood pressure gets measured and managed. A blind spot that affects the majority of adults over 65. That is visible only if you know to look for it. And that can be addressed meaningfully, practically, with tests you can ask for by name at your next appointment, and with habits you can change tonight. Let me start with the blind spot itself. When you see your doctor for a blood pressure check, the measurement takes approximately 30 seconds. 30 seconds out of the 86,400 seconds that make up a single day. That 30-second snapshot, taken in a clinical environment, often after you have been sitting in a waiting room on the best day you have had all week, is the basis on which your entire treatment approach is typically built. The problem is that for the majority of those 86,000 seconds, you are not in a doctor's office. And for approximately 8 hours of every single day, you are asleep. And those 8 hours are, it turns out, the most cardiovascularly significant hours in your entire 24-hour cycle. Here is what your cardiovascular system does, or is supposed to do, while you sleep. Under normal, healthy conditions, blood pressure drops during sleep by approximately 10 to 20% compared to daytime levels. This is called the nocturnal dipping pattern, and it is not incidental. It is not simply what happens to blood pressure when the body is resting. It is an active, essential physiological process on which your cardiovascular system depends. During those hours of reduced pressure, your heart is under less mechanical stress and can perform repair processes that are not possible under full daytime load. Your blood vessel walls are experiencing lower distension and can recover some of the elasticity that daytime pressure demands on them. Your kidneys, which regulate fluid balance and blood pressure through multiple hormonal and filtration mechanisms, use the overnight window of reduced pressure to process waste and recalibrate the systems they manage. Your autonomic nervous system, the branch responsible for regulating heart rate, vessel tone, and blood pressure, shifts toward its parasympathetic, restorative state. All of these processes depend on that nighttime pressure drop. It is your cardiovascular system's maintenance window, the hours when the engine gets serviced. Now, here is what changes after 60. Arteries stiffen progressively with age. The elastic tissue in vessel walls, elastin, is gradually replaced by less flexible collagen. The walls lose their ability to expand and contract in response to pressure changes with the same ease they managed in younger decades. The autonomic nervous system, which controls the nighttime dipping pattern through carefully timed hormonal and neural signals, becomes less precisely calibrated. The signals get weaker. The timing becomes less reliable. For a significant proportion of adults over 65, the result is that the nocturnal dipping pattern stops happening. The blood pressure either remains elevated during sleep at levels close to its daytime readings, or, in the most concerning pattern, actually rises during sleep, reaching its highest point of the entire 24-hour cycle in the middle of the night. We have clinical names for these patterns. People whose blood pressure does not drop adequately overnight are called non-dippers. People whose blood pressure rises above daytime levels during sleep are called reverse dippers. The prevalence of these patterns after 65 is striking. More than 50% of adults in this age group are non-dippers. More than half. This is not a rare clinical finding. This is the majority pattern in this population. And it is almost never detected by routine office visits, because routine office visits are measuring a 30-second daytime snapshot and calling it sufficient. The cardiovascular consequences of non-dipping are serious and well documented. Non-dippers carry a cardiovascular mortality risk approximately 3 times higher than people with identical daytime blood pressure readings who have a normal nocturnal dipping pattern. 3 times higher risk, with the same daytime number, the same medication, the same apparent picture on the standard assessment. The difference is entirely in what happens during those 8 overnight hours. For reverse dippers, the numbers are even more sobering. The stroke risk in reverse dippers is 4 to 5 times higher than in people with normal dipping patterns, and they feel completely fine during a standard office visit. Their daytime reading looks acceptable. They are sent home reassured. I want you to sit with what that means. The standard measurement tool that forms the basis of most blood pressure management is not designed to detect the pattern that carries the highest risk. It sees the daytime. It misses the night. And the night is where the damage accumulates. Let me give you a concrete example of how this plays out. A patient comes in for a routine visit. Blood pressure 120/78. Perfectly normal. His doctor is satisfied. He goes home with a monitor that takes readings every 30 minutes for 24 hours. Normal enough daytime readings. He goes to sleep around 11. By 2 in the morning, his blood pressure is 164/102, a hypertensive crisis, while he sleeps peacefully with absolutely no awareness of what is happening. This is not an exceptional case. I have seen variations of this story repeatedly, and the silent damage from those nightly spikes to the arterial walls, to the kidney filtration vessels, to the tiny capillaries behind the eyes, accumulates month after month, year after year, without a single symptom to prompt a visit to the doctor. Now, let me tell you why this happens, because understanding the mechanisms helps you understand both the solutions and the questions to ask. There are 3 primary drivers of this pattern in older adults. The first is medication timing. Most antihypertensive medications are taken in the morning. The protective effect of most blood pressure drugs peaks within a few hours of ingestion and then gradually diminishes throughout the day. If you take your medication at 7 in the morning, by midnight its protective window has largely passed, precisely when your blood pressure may need it most. This is not a failure of the medication. It is a timing mismatch between when the drug is taken and when the pressure problem occurs. The second driver is the disruption of the normal cortisol and adrenaline rhythm. In a healthy circadian pattern, stress hormones follow a clear arc, lower at night, rising in the early morning. In many older adults, this rhythm is disrupted. Cortisol and adrenaline levels do not drop as expected during sleep. Instead, they may remain elevated or spike during the night, activating the sympathetic nervous system, raising heart rate and vessel tone, and pushing blood pressure upward during the hours when it should be declining. The third driver is sleep fragmentation. Even brief awakenings during the night, the kind that do not register as full wakings in your memory, trigger sympathetic nervous system activations. Each one produces a brief but real pressure surge. If these microarousals are happening multiple times per hour throughout the night, the cumulative effect on nighttime blood pressure is significant. Sleep-disordered breathing, including sleep apnea, which is considerably more common in older adults than is generally recognized, is one of the most powerful drivers of both sleep fragmentation and nocturnal hypertension. Understanding these 3 mechanisms tells you something important. Nighttime blood pressure problems often have multiple contributing causes running simultaneously, and addressing them requires a more complete picture than a single daytime measurement can provide. Before I tell you what to do about this, let me tell you about 3 things that may be in your home right now that are silently worsening your nighttime blood pressure. Because this is the part of this conversation that surprises people most. The first is licorice root. I know this sounds like an unlikely health risk. It is an herbal ingredient, natural, calming. Many people drink it in the evening as part of a relaxing tea routine. But licorice root contains a compound called glycyrrhizin that blocks a specific enzyme in the kidneys responsible for breaking down cortisol. When that enzyme is blocked, cortisol accumulates in the bloodstream. Elevated cortisol at night activates the sympathetic nervous system, raises blood pressure, and directly undermines the nocturnal dipping pattern. The problem is that licorice root does not always appear clearly on labels. It is listed as sweet root, glycyrrhiza, or buried inside the phrase natural flavoring in blended herbal teas. Tonight, before you make your evening tea, read the ingredient list on every herbal blend in your cupboard. If licorice root appears in any form, that tea should not be part of your evening routine. This is a genuinely common and genuinely overlooked contributor to nighttime hypertension in older adults. The second is evening alcohol, and what I am about to explain surprises most moderate drinkers. The initial effect of alcohol is vasodilatory. It temporarily lowers blood pressure, which is why some people report feeling more relaxed after an evening drink. But 3 to 4 hours after consumption, as the alcohol is metabolized, something else begins. The sympathetic nervous system overcorrects. Cortisol surges. Blood pressure can spike to its highest point of the entire 24-hour cycle, at 2 or 3 in the morning, while you are sleeping, while you feel nothing. If you are drinking alcohol regularly in the evening and wondering why your morning readings or your energy do not reflect the quality of rest you feel you had, this mechanism is very likely a contributing factor. This is not about eliminating alcohol. It is about understanding the 3 in the morning consequence and making an informed decision about timing. The third is grapefruit juice, specifically when consumed alongside calcium channel blockers like amlodipine, which many older adults are prescribed for blood pressure management. Grapefruit contains compounds called furanocoumarins that inhibit the liver enzyme responsible for breaking down these medications. When that enzyme is blocked, the drug accumulates beyond its intended concentration. What was designed to provide gradual, controlled pressure reduction becomes unpredictably prolonged and intensified. This is particularly dangerous at night when there is no monitoring, no one to observe symptoms, and no easy way to respond. If you are on any calcium channel blocker and consuming grapefruit juice, even occasionally, this conversation needs to happen with your doctor. Now, let me tell you how to actually find out what your nighttime blood pressure is doing. Because everything I have described so far is the problem. This is the part where we address it. There is a test designed specifically for this question. It is called ambulatory blood pressure monitoring, ABPM. You wear a small, lightweight cuff for 24 hours while going about your normal daily life. The cuff takes automatic readings every 30 minutes, day and night. You wear it through dinner, through the evening, through sleep. The resulting profile shows your blood pressure pattern across the full 24-hour cycle, including those critical overnight hours. ABPM is the gold standard for identifying non-dipping and reverse dipping patterns. It is the only way to see your true nighttime blood pressure. It is affordable, widely available, and yet most people over 65 have never worn one, because it is almost never ordered unless specifically requested. Ask for it by name at your next appointment. Write it down now if you need to. ABPM. 3 letters that could provide the most complete picture of your cardiovascular risk your doctor has ever had access to. The second test is urine microalbumin. This measures tiny amounts of a protein called albumin that leaks into urine when the kidneys are under pressure stress. Microalbuminuria, the presence of albumin in the urine at levels above normal, is one of the earliest detectable signs of organ damage from sustained elevated blood pressure. It appears years before kidney function visibly declines on standard tests. It is a warning signal while there is still meaningful time to change the trajectory. It is a simple urine test. It is inexpensive. It should be part of routine monitoring for any older adult with hypertension. It almost never is, unless specifically requested. The third test is oxidized LDL. You know LDL as the standard bad cholesterol. Oxidized LDL is what happens when LDL is chemically damaged by the free radicals generated by inflammation and oxidative stress. Essentially, rusted cholesterol, far more destructive to arterial walls than non-oxidized LDL. Standard lipid panels do not measure it, but it is a direct marker of the arterial wall damage that sustained nighttime hypertension accelerates. It tells you whether the pressure is already leaving its mark on the vessels. These three tests together, AB-ABPM, urine microalbumin, and oxidized LDL, provide a clinical picture of your cardiovascular status that no standard checkup currently offers. All three are affordable. All three are available at most clinical laboratories. All three will almost certainly never be ordered unless you walk into your appointment and ask for them by name. Write these down somewhere you will find them before your next appointment. ABPM, microalbumin, oxidized LDL. That is your agenda. Now let me address solutions, starting with the most overlooked one, medication timing. The Hygia chronotherapy trial, one of the largest cardiovascular trials ever conducted, following 20,000 patients over 6 years, compared people taking their antihypertensive medications in the morning against people taking the same medications at bedtime. Same drugs, same doses, same patients, different timing. The results were remarkable. The bedtime group showed nearly 50% lower rates of heart attack, stroke, and cardiovascular death. Nearly half. From changing when an existing medication was taken. This finding has generated some academic debate. Subsequent trials have shown more mixed results, and the magnitude of benefit in the Hygia trial has not been uniformly replicated. But the underlying mechanism is sound, matching the timing of medication to the period when blood pressure protection is most needed. And the conversation about whether your specific medications might be better timed in the evening is absolutely worth having with your doctor. I must be clear about this. Do not change your medication schedule on your own. Some medications, particularly diuretics, should not be taken at bedtime because of the obvious practical consequences of increased urinary output during the night. Your doctor needs to review your specific medications and your specific situation before any change is made. But asking the question, have you considered whether my medications might work better taken in the evening given my nighttime pressure pattern? Is a question you have every right to ask. And it is a question that might meaningfully change the answer. Now let me tell you about something with genuine clinical evidence that belongs on your evening routine. Hibiscus tea. Specifically, the dried flowers of Hibiscus sabdariffa, the deep red variety used in traditional herbal preparations across West Africa, Latin America, and the Caribbean. Hibiscus contains a high concentration of anthocyanins, the same class of potent antioxidant pigments found in blueberries, pomegranates, and red cabbage. Anthocyanins neutralize the free radicals that damage arterial walls and contribute to oxidized LDL accumulation. But hibiscus does something more specific than general antioxidant activity. Hibiscus anthocyanins inhibit ACE, angiotensin-converting enzyme, the same enzyme targeted by one of the most widely prescribed classes of blood pressure medication. ACE inhibitors work by blocking the conversion of angiotensin 1 to angiotensin 2, a potent vasoconstrictor that raises blood pressure and promotes fluid retention. Hibiscus achieves a milder version of this same pharmacological mechanism through naturally occurring plant compounds. Multiple randomized controlled trials have examined hibiscus tea and blood pressure. A study published in the Journal of Nutrition found that adults with pre-hypertension or mild hypertension who consumed hibiscus tea daily for 6 weeks showed significant reductions in systolic blood pressure in the range of 8 to 14 millimeters of mercury compared to placebo. A meta-analysis published in the Journal of Hypertension, pooling data from multiple trials, confirmed a consistent blood pressure lowering effect across the included studies. These are not marginal findings. A reduction of 8 to 14 points in systolic pressure is clinically meaningful. Preparation matters enormously here. Most people prepare hibiscus tea too weakly to achieve any meaningful therapeutic effect. The difference between a medicinal preparation and a dilute flavored drink is almost entirely in how you make it. Use 10 grams of dried hibiscus flowers, the whole dried calyces, not tea bags, not blended herbal mixes, not flavoring. Actual dried hibiscus flowers, available at health food stores and online. Water heated to approximately 90 degrees Celsius, just below a full boil. Pour it over the flowers and steep for a minimum of 10 to 15 minutes, covered. The color, when properly prepared, should be a deep, rich burgundy, almost the shade of dark red wine. If your cup looks pale pink, the extraction is insufficient. Steep longer or increase the amount of flowers. The most important cup of the day for blood pressure purposes is the evening cup, taken 1 to 2 hours before you sleep. This is the timing window where it has the most meaningful overlap with the overnight blood pressure period you are trying to support. One important safety note: if you are on blood pressure medication, do not add hibiscus tea to your routine without telling your doctor first. The combined effect of hibiscus and antihypertensive medication can be additive. Your blood pressure may drop more than your medication was calibrated for. This is not a reason to avoid hibiscus. It is a reason to have the conversation first. Your doctor can monitor your readings and adjust if needed. Let me now give you 3 specific things you can do tonight and tomorrow. Not a complicated protocol. 3 things. Tonight, go to your tea cupboard. Read every label on every herbal blend. Look for licorice root listed as glycyrrhiza, sweet root, or natural flavoring in any herbal blend. Any evening tea containing licorice root should be moved to morning use or removed entirely. That single action may meaningfully improve your nighttime blood pressure pattern. Tonight, think honestly about your evening alcohol pattern. Not harshly, just honestly. Is it regular? Is it close to bedtime? If so, the 3 in the morning pressure spike I described is a real and recurring event in your cardiovascular night. You do not have to eliminate it, but shifting it earlier, with dinner rather than in the hour before sleep, reduces the magnitude and timing of the rebound effect significantly. Tomorrow, write down 3 things on a piece of paper and put it somewhere you will find it before your next doctor's appointment. ABPM, microalbumin, oxidized LDL. Those are your 3 requests. Affordable, available, and together they will show your doctor and show you what your cardiovascular system is actually doing during the hours that matter most. I want to close with something I think is worth saying directly. Your doctor is working with the information they have access to, and in most routine appointments, that information is a 30-second snapshot of one of the least representative moments in your cardiovascular day. That is not a criticism of anyone. It is a structural limitation of how standard care is delivered. The solution is not to distrust your doctor. The solution is to walk into your next appointment better informed than most patients, knowing what tests to ask for, knowing what questions to raise, knowing what to discuss about medication timing and nighttime pressure patterns. Patients who come in prepared, who bring a list, who ask specific questions, who follow up on specific concerns, consistently receive more complete care. The research on this is unambiguous, and it matters clinically. You now know that more than half of adults your age are carrying a nighttime blood pressure pattern that their routine care is not detecting. You know the 3 tests that can detect it. You know the things in your home that may be worsening it. You know the research on medication timing. And you know that a simple, inexpensive cup of properly prepared hibiscus tea in the evening has genuine clinical evidence supporting its use as a daily nutritional measure. That is a meaningful amount of knowledge to walk into an appointment with. Your heart has been working for you every hour of every day and every night of your entire life, without pause, without rest, without complaint. It deserves the most complete, most informed attention you can give it. Walk into that appointment prepared. Ask the questions, request the tests, have the conversation about medication timing. Add the hibiscus, remove the licorice. These are not dramatic interventions. They are informed, specific, evidence-backed steps that address a real and under-recognized risk in exactly the population most affected by it. If this was useful to you, please subscribe to the channel and share this with someone over 60 in your life who checks their blood pressure and feels reassured by the daytime number, without knowing what is happening at 2 in the morning. They deserve to know that the full picture is worth looking for. Leave a comment below. Have you ever had a 24-hour blood pressure monitor? Has your doctor ever discussed your nighttime pressure pattern with you? Your answers help me understand what this community needs most. I am Dr. Julian Cross. Take care of yourselves tonight, and I will see you in the next one.